Well, good afternoon, everyone. We're going to wait just about one more minute before we get started, just to give everyone a chance to join. I can see the numbers creeping up here, so we'll just give it another minute to let people get on. Well, welcome everyone. I know we've got just about 45 folks on, and I'm sure those numbers will continue to climb. I want to thank you for joining us today on this Zoom AAA webinar, the clinical update for COVID. Again, being joined by, of course, Dr. Racht, the GMR's medical director, and Randy Strozyk, another GMR executive, and president-elect of the American Ambulance Association, active member. So it's been 26 weeks since the last time folks have had to put up with our three knuckleheadedness and talking about COVID and providing some information. So I just want to, of course, thanks. When I reached out to Randy asking if, because Randy is Dr. Racht's handler, asking if he would kindly ask Dr. Racht to do one of these to talk about vaccinations, because we know there is a ton of activity relative to vaccinations. So as we're moving along here, just wanted to say that we are, of course, also simulcasting onto Facebook Live as well. And so this is going to be recorded so that if you are unable to join us live, certainly you can watch this at a later time, as well as a quick couple of housekeeping things. If you want to engage us, any of the speakers, certainly you can informally do so through the chat feature in Zoom, or you can submit right through the Q&A section in Zoom as well, and we will get to those questions. We'll try to get to as many of those as we can. I will say as a preface, Dr. Racht does have to jump off a little bit before, or I think partway through, because I think you have a call with like really important people in the government, right? If I'm not mistaken. So
they're from the government. They're here to help.
From the government, they're here to help. That's right. So if you have a question, certainly, please, I welcome you all to go ahead and use either the chat feature and or the Q&A feature. So I'm going to, thank you, Dr. Racht, for joining us again. I know I've seen you on television a lot lately talking about this. So thank you both. Dr. Racht, I'll let you take it from here.
Thank you, Scott. That was actually the episode of The Simpsons you were thinking of. So, hey, all. Thank you for joining in this never-ending adventure in COVID land. Scott and Randy have asked to kind of do an update in really what's become, Scott, we get the next slide there, become the next section of the next chapter of the book of COVID. So this, I have to tell you, as much as we've talked and as much as I personally, I'm tired of this. I'm tired of, before we started, the three of us were talking about our own colleagues who are sick or who are hospitalized. This is taking its toll on healthcare. It's taking its toll on everyone, in particular in EMS. But I got to tell you, this particular piece is really, really positive for me. Next slide. So I want to talk about the new hand sanitizer. Obviously, this works really well. Use it on your hands. You're going to touch your eyes a hell of a lot less than you normally would. Next slide. 319 days. I put that number up because that's the number of days that it took, the amount of time that it took from the new onset of this particular virus identified in the United States to the FDA, EUA approval of the first vaccine. That is unheard of. That is phenomenal. And that's the good news and the bad news. The good news is phenomenal development, rapid. The bad news is it created suspicion. It created suspicion because of the cultural environment, because of the political environment, because, I mean, are you kidding me? You created a vaccine in 319 days? No, I'll wait for the one that takes years that's deemed to be more safe. Next slide. So if you look at our infectious journey, any infectious journey, whether it's Ebola, whether it's this particular agent, there's a series of events that we go through, right? First, you have to notice that there's a potential infection. It's like, what the hell is this? This is a sign syndrome complex that I've not seen before. We've not seen before. You explore what it is. Then you have to identify the infectious agent itself, which we were able to do globally, in a relatively short period of time. Next, you have to understand and reduce transmission. This took us a long time. Matter of fact, we are still learning about how to reduce transmission. We're still looking at the impact of various physical distancing, masks, of preventatives, and trying to sort out exactly how to reduce transmission effectively. Then we try and prevent future infection. And we are there today. So this is why it's an exciting time. Once an infectious agent is identified and we develop a vaccine or prevention methodology, we begin that journey to say, okay, Skippy, you were here, you caused a lot of problems, you're gone. We're building the structure to prevent you from infecting other individuals down the road. And then finally, the surveillance of illness and monitoring for change. That's why the CDC has reportable illnesses to monitor when we start to see a reemergence of an infectious agent that historically we've been able to control. Next slide. So pertinent to what I want to talk about are three things that, and while this looks like by the way, if this were my board exam slide and I had to match the column on the left with the pictures on the right, I wouldn't be talking to you. I'd be doing something else totally different, welcoming you into Walmart and pointing you to the direction that you needed to go. But for purposes of vaccines, there are three things that are really important: the macrophage, the B lymphocyte, and the T lymphocyte. And before you go, God, are you kidding me? I can't believe you're talking about this. I'm talking about this because remember I talked about good news, bad news, and this concept of our big risk is that culturally, we're not going to accept this as a population, which means we won't reach the critical immunity to minimize the further transmission of this infectious agent. So understanding is important. You and I have two kinds of responses. Innate, our mommies gave us to preventing infection. It's the skin, it's that initial response. It's a macrophage that says to a foreign object, to an infection that comes into the body, that gets into the nose, the macrophage says, hey, you're not from around here. What's going on? And the macrophage goes and attacks it. We are born with that. We're born with this surveillance system that essentially patrols around and says, when something foreign comes in, attack it and get rid of it. Very quickly, those macrophages become overwhelmed with an increasing viral load because some of those viruses slip by, they start to reproduce, they start to then end up being a larger burden that innate response is unable to keep up with. So then they recruit the B and the T lymphocytes. So that cellular immune response or that adaptive immune response does a couple of things. The B lymphocytes, as part of the white blood cell system, the B lymphocytes make antibodies. I'll never forget, this is so stupid. When I was in medical school, one of my buddies said, hey, Racht, we're trying to figure out how to remember B versus T. And he said, it's pretty easy. The B lymphocytes are antibodies. It's like, thanks there. That helps a lot, Skippy. The B, if there's the letter somewhere in the word, you'll remember it. So B lymphocytes make antibodies. They produce the antibodies that attach to the outside of that foreign object. So if you think about B and T lymphocytes, the B and T lymphocytes are special operations, right? They're spec ops. They say the macrophages were unable to manage this infection, this infective agent, ramp up, we got to go in. B lymphocytes create the antibodies. The T lymphocytes then start to explore. There are different kinds of T lymphocytes, but they explore what's going on. They stimulate the immune response to create more antibodies, and they start killing those infectious agents that have those markers, those antibodies on the outside. So if you've ever seen the Far Side comic where the deer has that birthmark that looks like a target, and it says, hey, bummer of a birthmark, Hal. It's the same thing here. The antibody attached to something says, get rid of it. You are flagged. So the importance of the B lymphocytes that are producing those antibodies and T lymphocytes that are running around killing things is that the T lymphocytes have a memory. They remember, and they say, you know what? We're not going to allow this to happen again. We're going to remember exactly who this is. We're going to have a storage of those antibodies hanging out so that when it comes again, boom, we're going to be able to respond very quickly. Next slide. So I want to talk about messenger RNA. And by the way, it's not my intent in this discussion to go, although I'm happy to answer the questions, to go through a lot of the specific information relating to who gets a vaccine, how it's distributed, because I think that's readily available. But again, happy to answer questions about that. I want to talk about some of the things that impact adoption, some of the worries, some of the concerns, some of the yield and caution signs that are out there. So a lot of suspicion by some of messenger RNA because it's perceived that if I get RNA into me, it's going to incorporate into my cells then change. And then I develop a third eye, or I end up with some longer term illness, or I end up not being able to fight some other infection, or I end up developing cancerous cells. Because messenger RNA is the teacher, it's the map. It goes into the body and it says, here is what I want you to build. It's the instructions. It's not the operator, it's the instructions. It's non-infectious. So when people say, well, look, I got the vaccine, it's messenger RNA, and I got a fever, so something's going on. I'm going to talk about that in a second. That's really important. It does not enter the cell nucleus, meaning it does not get incorporated into the host DNA. As a matter of fact, the body's really good with this. We love it and leave it. The messenger RNA comes in, it stimulates the cells to produce a component of the spike protein on the virus so that it now becomes recognized. So think of this as when you walk into an area and say, oh, I'm in a Marriott, or you smell something and say, I know what cologne that is, or you hear a song and you say, oh, I remember when we listened to that in Christmas when I was growing up. The messenger RNA creates that memory. It goes in, it stimulates a cell to create the memory, that little bit of protein, not even the full spike protein, and then we destroy it. So the messenger RNA is destroyed by this same immune system. It has the potential to become a multi-infection vaccine tool, meaning if you have messenger RNA for all the things that we don't want to get, right? We end up with, could you imagine, and by the way, this is me, I've not heard this being discussed, but could you imagine a vaccine that was measles, mumps, rubella, COVID, influenza, and a different group of infections? Can you hear me?
Yep.
Oh,
Yeah,
sorry.
you're back.
I didn't know if it was, sorry.
Yeah, you had disappeared for a minute, but you're back.
Yep, sorry.
Right.
And this is also it's not foreign in medicine. So messenger RNA is used in oncology to create specific proteins to target specific tumors. And it is much, much, much faster to develop and implement, which is why they were able to develop these vaccines so quickly. Next slide. So out comes Pfizer. The Pfizer vaccine was given emergency use authorization by the FDA, is now out, as is the Moderna vaccine, in widespread distribution throughout the United States. Next slide. So there's something that's really important here that I think really helps understand this. The Pfizer and Moderna vaccines in their 20 to 40,000 groups of phase 3 trial patients that they were used in were demonstrated to be 95% effective. And when you look at that effectiveness rate, seasonal flu is about 40 to 60%. Matter of fact, when we get a seasonal flu vaccine that's 60% effective, it's like, yes, we nailed it, right? We nailed it this year. This is 95%. Let's go to measles, mumps, rubella, which all of us have also had. First dose, 93% effective for measles, 78% effective for mumps, and 97% effective for rubella. So that 95% of the messenger RNA vaccine is really important for us. And by the way, all of this data, you all know this, was reviewed both internally and externally, and was not influenced by sorry, the end result was not influenced. I have no idea in the intermediate spot, but all of our research, epidemiology, and vaccine pharmacology partners are very comfortable with the process that it went through for approval. Next slide. So where are we today? We've got the EUA for Pfizer and Moderna. They are running around in communities as we speak. Both of those vaccines are mRNA vaccines. They are, as I said, they're being administered, they're shipping. About 3 million individuals have been vaccinated to date. Most of those are frontline healthcare providers. A close number two, obviously, our long-term care population. It's easier operationally to vaccinate frontline healthcare workers because they can often come to the vaccine as opposed to the vaccine going to long-term care, which, as you know, is in phase 1. So what's important for us, I think, if you look at what CDC did a couple of days ago in this next wave of vaccines, the first responders are included in that. So there's this sense by some, there's confusion. EMS was included in the priority, and then you get this recommendation that first responders. In terms of the first responder, that next piece, that's really focused on law enforcement, that's focused on non-medical fire, public safety out there. EMS, fortunately, was covered under that healthcare. And by the way, if you remember going back in our PPE discussions and testing discussions, this is the first time that they looked at EMS, looked at us and said, okay, Skippies, you're in that first group. So there's a lot of success hidden in the fact that those large organizations said in the first group include you and I, the emergency medical services piece. Next slide. What's on the horizon? So, well, the asterisk on the horizon is because this is subject to dramatic change, and everyone knows that. The volume of Pfizer, given a supply chain challenge, was reduced substantially from the initial piece. We are aware, even as of today, of vaccines that have been shipped. You know, they have a monitor. The Pfizer vaccines have a temperature monitor in there. They were shipped. They did not pass the cold chain, consistent cold chain documentation. So the vaccines are considered non-administratable. So we know that that's going to happen. 20 million vaccines are supposedly going to be available by in a few weeks, the beginning of January. 30 million additional vaccines during the month of January, and then 50 by the end of February. Our public health folks say that the general public, not the high risk general public long-term care, but general public, are probably slated for late February, early March. A lot of folks think that that's pretty aggressive, and it may be later than that. And there are 2 manufacturers in phase 3 currently in the US, 2 additional manufacturers in that final phase. Next slide.
Real quickly, Ed.
Yeah.
With next to the Johnson & Johnson and AstraZeneca, those are not going to be mRNA, are they not? They're going to go back to the traditional using protein-specific group?
So I don't know specifically, because I heard one of them is a combo. Okay. So I can look at that, Randy, but I can't answer that okay. Effectively.
Got it.
So look at the number of vaccines that are out there. This is updated today. If you look at phase 1, which is hey, I wonder if this will work. There's 43 worldwide out there, and 1 has been abandoned after the trial, side effects, and then the 3 approved. Remember, this is worldwide. Next slide. To your point, Randy, to your question and to your COVID coughing there, yeah, I'm telling you, I've said this before, man. I would rather have a surgical crike in certain circumstances than cough, because everybody else looks at you like you've got it. So there are 3 types of vaccines to your question. The mRNA, which we've talked about, the protein subunit, which is a little bit of the protein, the actual virus protein that's injected for the cells, the host, to then create antibodies to, and then vector vaccines. So you know vector vaccines. Vector vaccines are beat up virus. They are, so if you remember flu mist beat the virus up so that it can't fight back, but inject the infected agent so that the body can develop an immune response. If you look at the 3 of these, if you had to pick, the mRNA is probably the safest of those three different categories, because there are no actual virus particles, there are no virus that are injected into the new host. Next slide. So there are important details associated with where we are. Shipping, storage, logistics. This is hard. It's not easy. You know, it initially was going to be easier. Obviously, the Pfizer requires Arctic level dinosaur, prehistoric, fossil storage, and very limited interruption of that storage. The Moderna requires much more traditional refrigeration. Documentation still evolving. Who needs to know what? This is a big initiative, and states, as you know, states are responsible for developing deployment strategies. In our day job, the variability from state to state, because we're in so many different states, is fascinating. There is not a single unified approach to most of this. I think some of those things will develop. Follow-up dosing. Remember that a lot of these are scheduled. I may be in an area, I may come to you at your main headquarters and say, okay, Tuesday at 3 till 9 p.m., we're going to be out there giving you vaccines. And we're going to be back 28 days later, Thursday from 3 p.m. to 9 p.m. If I miss that, I'm not there. I have to get my follow-up dose somewhere. So the follow-up second dosing, and remember that 21 and 28 days is based on some data, but not solid data. That's soft as soft can be. It's a booster dose. And that was deemed by both of the manufacturers to be the acceptable dosing that was given to their phase 3 trial participants. So what CDC recommends is if you miss your second dose, get it as soon as you can, You don't have to go back and get the first dose again and the second dose. And by the way, they're equivalent doses. They aren't different. The state differences we've talked about. Pediatric patients, they're starting to explore that in the pediatric population now, but there is no good data for administration in pediatric patients. Pregnant patients, it is deemed to be safe, but based on the decision of your practitioner and the patient themselves. So that's still a gray zone. Timing of the vaccine post-COVID, current recommendation is wait about 90 days, not because that's how you'll develop your immunity, but you probably have some developed immunity from the infection that will carry you over for that time period. So allow the vaccines to be given to others. And then post-vaccine administration monitoring. So 15 to 20 minutes for the non-allergic and 30 minutes for those who have a history of any kind of an allergic reaction. Next slide. Sorry, Scott. So this is the stuff you're probably hearing, and then I wanted to go through. So 6 people, probably 7 as of a few hours ago. There was another one in New York that was reported. So 6 or 7 out of 272,000 Pfizer vaccinations developed anaphylaxis. And there's a question of whether that's to the virus itself, to the mRNA, to the viral material, vaccine material itself, or to the vehicle, the polyethylene glycol. But it is 6 out of 272,000. What's important here is we don't expect this vaccine to be 100% safe and 100% effective. I wish it were. What we want to do is make sure there aren't significant outlying either conditions, circumstances, which I'll get to in a minute with the Bell's palsy, or that the volume of significant reactions is not higher than would be expected for this vaccine. But that's why we monitor, right? And that's why when you get the vaccine, particularly if you have a history of anaphylaxis, you're monitored for an extended period of time. Also on the Pfizer side, Bell's palsy became a big issue. As of December the 10th, there were 4 identified cases in patients, individuals who had received the vaccine. The current evaluation of that is that it may not be related to vaccine administration. And there is no indication to stop or consider that a risk at this point. The vaccine population risk, if you look at that, was 11 out of 100,000 administrations. The general population, totally outside of this, are 23 cases of Bell's palsy out of 100,000. So that could be related to general population acquiring that particular abnormality.
Dr.
Next.
Just looking
Yes.
quick at the MMR vaccination, right? According to some of the statistics I've seen, that's compared to 1 in 3 or 4,000 negative reactions to an MMR vaccination, or 1 in, I think it was 1,000 in the flu vac. So comparatively speaking,
Yeah.
this is like beyond safe.
Yep.
Right.
And Scott, you're spot on. Some of that is a little bit tainted by the definition of what those reactions were, but you are absolutely right. If you had to choose a vaccine that was deemed safe based on our current data, the COVID, the Moderna and the Pfizer, which we have data on, are clearly safer.
And just
That's right.
the one point that I think I've heard from folks a lot has been, geez, it was developed so quickly. Really, the reason why it was developed so quickly was because of the mapping of the human genome, correct? Right. Essentially, that permitted us to create a superhighway right to RNA type vaccinations, if I'm not mistaken.
Yes.
And that really has that's why when you looked at polio, it took X number of decades, right?
Yeah.
So for folks, this really, they need to understand, like, we're people of medicine, right? Like, and I know people of medicine use science. And so for folks who are uncomfortable or nervous, they need to look at the facts and the statistics. Is that fair?
Yep. Nope, that's very fair. It's the perfect storm. Not only do we know how to map genomes and figure that out very quickly, but we don't have to culture, Bavarian mountain fainting sheep cells in culture, right, over decades to create the right kind of medium to grow the virus in something that simulates the human environment and test it. So you're spot on, Scott. It's easier to do. The technology's better. One of my colleagues said it best. It's the 3D printing. You look at what you're able to do. So, the space shuttle sends up a bunch of 3D printers. They need a tool. They send them the code, zing, 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 and your tool is 3D printed. So it's a similar kind of analogy. Spot on.
One of the other things that I heard was that the federal government provided some liability protections during these trials that actually allowed, for, principally, like, if I'm not mistaken, what I heard was that the government did provide some of these vaccine manufacturers with some protections that essentially said, look, this will allow you to speed up your trials without concerns about some of the traditional liabilities that one might see, which then allowed them to, frankly, not that they didn't have the safety protocols, they did, right? They just didn't have to act so, most times I think they're being super, super cautious for that 1/100th of 1% of the time that somebody's going to sue them. Right. In this instance, there were some liability protections because the government recognized this needed to happen and it needed to happen fast. Is that?
If I can, Scott, great. Thanks for the lawyer question. But Ed, I need to time manage you. You've got to get HHS calls. So
welcome to my world.
Yeah.
I told you.
Hey, well, if you
got it. I got it.
Go handler if you want them, right?
So Scott, to your point, yes, you're right. And the entire administrative envelope around development, testing, review, and release is totally different for these vaccines than we've ever seen in the US.
Yeah. And I'm guessing something launches when I click on this thing, right? Oh, there we are. Bottom line.
So, bottom line, the initial data, and I put the initial data in there specifically because, look, nobody can tell us what the long-term impact will be. We've got some suggestions based on how mRNA is used in oncology. It's been explored in Zika vaccines and influenza as well. But the long-term component will be sorted out. The short-term and the intermediate term, very safe. And to your point, Scott, probably safer than what we've historically seen. Logistics are challenging. They're going to evolve. And that cultural acceptance is critical. Trust, to your exact point. It's been fast. It's been not like traditional. We haven't had to wait. We used to have to make all of our own blood by hand when I was an intern at a resident, right? And then monitoring post-vaccine. So there is a very aggressive post-vaccine monitoring, several programs, including apps, as many of you have seen, to monitor this down the road. And then finally, the discussions in the UK, the mutations that they're seeing now, most believe are not affecting the vaccine effectiveness. And I'm sorry for the double words there, but we have to watch that down the road because there may be mutations that do impact vaccine effectiveness. So that long-term monitoring is clearly going to be important. Next slide. One more. So from our first time together, when we started talking about this, which seems like forever ago, it's been a long journey. I got to tell you, two things, and we haven't talked about it on this call, and actually that's my next call. There are two things that really make me so thankful that science is emerging rapidly. One is the vaccines, as we've talked about, and two is monoclonal antibodies. So a lot of good data, a lot of good potential implications for use of that, including dramatically reducing severity in patients who are ill. So those two things really encourage me as a way to get out of the woods. So the last click there, it's been a different time. Clearly, I would have never imagined. Honestly, this is the first time that I feel a little bit more upbeat. There is light at the end of the tunnel, and we're seeing it now. And that's important. It's important for EMS to step up and be part of that. So.
Yeah, I know my wife got her first vaccination today and said that sort of for the first time in a long time, she saw what looked like a ray of hope in the medical center went in.
Yeah.
And that really, I think, from a mental health perspective is huge. I know you have to run. So and most of the questions or the comments that have come in about sort of been about where people are in their state relative to priority for vaccination. So I can't thank you enough. I know it's been 26 weeks, but it's good to see you again. Thank you for everything.
It's nice to see you all.
Not just for EMS folks, but or at FRAMR, but for everyone. So I'm really grateful. Thank you so much, and I hope you have a nice holiday.
Thank you so much. I appreciate it. Best of the holidays to you guys. Sorry I had to zing off.
That's all right. That's all right. So now this is where the numbers drop from 70 something down to 2 or 3.
Now they'll hang around.
Well, so I think part of the challenge that we've had, right, is number one is we've seen in the notes that we've seen from different folks around that, of course, the CDC, we lobbied hard to get EMS folks in that first tier. And then what we found out, of course, was recommendations of the CDC out to the states in which the states could really decide where our folks ended up in the tier or within those tiers. And so, I want to thank everybody who has gone through and commented as to where EMS has ended up in the distribution of vaccinations. Of course, if you're still lobbying, and I know in a lot of places, they are still lobbying to try and get priority for EMS. Of course, don't forget to utilize the AAA's toolkit. And really, frankly, this has been a year that I think EMS has had more exposure in the mainstream media than we have ever seen. And certainly, this is one of those times where really, more so than even I think when there's been terrorist attacks, right? This is one of those things that this has been the longest sort of stretched event for which our folks have just consistently time and time again stepped up to the plate and really gone above and beyond at a great cost to not only themselves, but their families. So utilize, if you're having struggles within your state, utilize the resources that are available to you. That's part of course, what we're doing here. So I want to talk just quickly about employee vaccinations and attitude. And I touched upon this a little bit, I think yesterday, but definitely last week. One of the things that we know is there have been several surveys out there, not only just globally. Gallup did some research that said something like 50+% of people would not take the vaccination. And then, of course, EMS1 and GEMS have done some surveys as well that suggest that 28% of respondents said that they would be willing to take the vaccination, and that 12% said only if they were mandated. I think one of the things that's important, and this came up during one of our workforce committee calls, was just when you ask a question such as, will you take it or won't you? And it's either an all yes or an all no answer. It's important that, I sort of seek first to understand is give your folks an option, right? It may be no or yes with more information. Recognize that your job as an employer, you certainly, and we'll talk about mandated vaccinations in a minute, you certainly can mandate it, there's no question. But the reality is you don't want to have to force or fight people to get a vaccination that frankly is going to help them, right? Given that we already know based upon the science that we've seen, we're medical people, so we work and deal with science. Not that we don't have some concerns that might even be a little bit unfounded, but really, really, really important that you recognize that you're giving your folks information. And that was part of what pushed and Randy and I were talking about getting Dr. Racht on, was to talk about the medicine, because the medicine itself, as you've seen, this vaccination is far less risky than virtually any vaccination that has come out in the history of this country. So this is one of those times that you need to be educating your people, because with good information and with, unbiased even sources, our folks will make the right choices. And I'm seeing some questions come up in the queue, and I will jump to them, but I wanted to make sure that if you are querying your folks, make sure you find out, again, for those folks who say that they don't want to get it, try and find out why they don't want to get it. And I will talk about this idea about ADA medical or reasonable accommodations in a second, but I want to talk about considerations for mandatory vaccines. So, and I can see, already a few questions have come up. Liability for employer if we make that vaccine mandatory. We're going to catch that in a second, and we'll talk about some of these. So first and foremost, one, you can make that vaccination mandatory for just about every single solitary employee that you have, with the exception of two really situations, possibly three. The first one, and we'll talk about this in the next slide, is the ADA medical condition. Second one being a religious objection. And then the third one possibly being some protected political activity. But just one of the challenges I've heard from a lot of folks are, well, we'd love to make it mandatory, but even if we do, we're not in a position, what are we going to fire people for refusing to take the vaccination? And the reality is most organizations are not in the place to actually do that. So, what if I mandate that employee and they have a negative reaction? Well, a couple of things that I'll say there. One, what if you don't vaccinate that employee and then they get COVID, right? So let me just tell you that if they in fact have a negative reaction, for which, by the way, we've seen is less likely than in the traditional MMR or flu vaccine by a long shot. But if they do have a negative reaction, would there be any employer liability? This would be just like any other employee or employer related illness and or injury. So what I would suggest is, in the event that they have a negative reaction, of course, follow the protocols. Your best bet, truthfully, if you want to talk from a liability perspective, is to use a third-party vaccination administration vendor. And I would strongly recommend that as you're engaging those folks, if in fact you're engaging the third party to do that, that you are looking at that service contract and some of those liability protections. All right. But one of the things that I would suggest for you is recognize you are actually at far greater legal risk, and by a long shot, of not vaccinating your folks, because, of course, OSHA has a requirement that you provide a workplace that is free from known hazards. This is a known hazard. You would want to make this available to your employees. What if the employee gets vaccinated and then still comes down with COVID-19? Same exact, you would treat this person the exact same way that you would treat someone who just came down with COVID-19 if in fact it were work acquired and or presumptively work acquired. What I will say to you is that would be highly unlikely, given that what we've heard is that the efficacy of that vaccination after just one shot is almost 93%, which is higher than virtually any other vaccine that's out there. So what I would suggest for you is, for the most part, these are those questions that they used to call in law school as the distractor questions, the questions that are intended to distract you from what the real issue is. And what I will say is, yes, if your employer refuses, do you have the right to take action? You certainly should. But what I would say is, you want to find out why, right? For the most part, you can mandate a vaccination if, in fact, as you analyze all of those positions within your organization, it is job related and consistent with business necessity, right? That is really what's called an ADA and or a Title VII type analysis. And what that really gets at is the employees who have a legitimate medical condition for which the employee themselves and their healthcare provider are concerned that the administration of this vaccination would in fact cause complications for them, then you as an employer are required to engage in what's called the interactive process, right? The reasonable accommodation interactive process. That is a dialogue, back and forth discussion between you and the employee and possibly the employee's healthcare provider to try and discuss sort of what is it that those concerns are, what are the potential issues. You can seek some limited medical information from that healthcare provider, but to try and understand why it is that that person, given that these risks really are very, very, very low. The next thing, and by the way, you don't have to give every potential requested accommodation. You only have to give those accommodations which are considered reasonable, right? But understand, even if you provide that reasonable accommodation and you still can't control or limit the risk or hazard in the workplace, then you may not have to provide it. So under the law, of course, if an accommodation would create an undue hardship upon an employer, and that typically is one that involves great expense or great difficulty, or in this instance, continues to actually doesn't essentially eliminate that hazard to an acceptable risk, well, then you potentially don't have to provide the accommodation. What I will say is you want to document this process. You want to document it from the request, have that person fill out a written reasonable accommodation request, and then make sure you're documenting that interactive process, that back and forth dialogue. Every single step of that back and forth dialogue you want documented, because in some states, New York, California, it's required that you're documenting that. But truthfully, it should be required in every single state. You should be documenting that. Number two, for religious, for sincerely held religious objections. So for employees who come in and say, receiving this vaccination will be against my sincerely held religious belief or the tenets of my religion. What I would suggest to you is, number one, again, same analysis, go through that interactive process, make sure you're documenting that process, have the employee document that this is a sincerely held religious belief. And in fact, you can request some documentation, let's say from their particular religious leader that might be able to support that religious belief. But what I will tell you is, again, you are not required to provide all accommodations, only reasonable accommodations. And even if you give that accommodation, you can't eliminate or provide or eliminate the hazard and make it safe for not only that employee, your coworkers, and your patients. Well, then you don't necessarily have to provide it. What I will tell you is, before you tell someone that you're going to still mandate that vaccination, even though they've cited an ADA concern or a religious concern, I would talk with your local council to make sure that you're taking the right steps to protect both you and the employee, honestly. And then political activity.
Hey, Scott, if I could interject, if folks either on the chat side or the Q&A side reference these 3 points, either ADA, religious, or political activity, if you've been formally approached by your staff about this or persons, would you mind just putting a note in that you've seen this and which one of those three fell into? It just give us a rough idea on a kind of an informal survey today.
Yeah, that would be great, actually. If folks are hearing from their staff that there are concerns about the vaccination, I'd love to hear, are these concerns generally based on the concern about the safety of the vaccination, or are they really tied to a legitimate medical condition or a religious condition? That's a great point. And I will say, so I saw in the ADA, does that cover mental health if for some reason a person has a phobia about needles? Well, phobia, it would really have to be a DSM-4. I think it might even be at the DSM-5. My undergrad was in psychology. So I think it has to be a recognized DSM-4 diagnosis in order for it to actually be considered a mental health protected disability. That being said, you would request that employee to fill out an ADA reasonable accommodation request. By the way, we're about to release this year's HR manual, which includes in it a whole ton of sample forms that members can just plug their own logo into and use, one of them being a reasonable accommodation request for ADA and or a reasonable accommodation request for religion, as well as a reasonable accommodation process worksheet for the employer to utilize as they work through these and document. So what I would say is, it's not just like, someone who comes in and says, oh, I have anxiety. A lot of people will say anxiety. There's a difference between being anxious about something and having an anxiety disorder as diagnosed and recognized by DSM-4 or DSM-5. I think it's still DSM-4. Next question is, yesterday you mentioned having employees who do not want the vaccination to sign a declination. Do I have a template? I actually have one out to my graphics person so that we can include it in this year's manual. So as soon as that's available, I'll make sure that gets punched out on the AAA website so that everyone can see it. The declination, I've sort of fashioned it after very similar to the hepatitis B vaccination declination. So in our organizations, you should be having your folks complete, if the hepatitis B vaccination or authorization, one that says, I'm declining the Hep B vaccination. Why? Because I already have it. Because it's entirely possible your folks got their vaccination somewhere else, because many of our folks work at multiple locations. So I'm declining because I've gotten it. I'm declining because of, maybe it's a legitimate medical condition, a legitimate religious objection, in which case we're going to reference those reasonable accommodation evaluation processes. And then I'm declining even because I do not want to take that vaccination. So when that form is available, we will make sure that we get that out. And Mark, thank you. It's DSM-5. I can always count on Mark to come through for the latest version of the psychological disorders. Thank you, Mark. Make no judgment about that. So I'll pay for that dearly. In any event, let's see, concerns my employees have expressed are regarding to the safety of the vaccinations. That's perfectly reasonable. And what I would suggest is, one, you could take the excerpt from this presentation that Dr. Racht did. There's also an amazing explanation by a physician down in Florida. In fact, the Florida Ambulance Association had made this video available. It's about 24 minutes long, which I know for the most part, nobody in the world, like I'm always told, don't write anything that lasts more than about 2 minutes to read. But it's probably one of the best explanations I've ever seen for why you should feel comfortable taking this vaccination. And then certainly, but Dr. Racht puts it in a way that is so easy for EMS folks to understand it. And he's a trusted individual. If an employer refuses the vaccine and then develops COVID, would that mitigate work comp liability for the employer, possibly under the assumption of risk theory? So interesting. No, actually, as far as I know, in most now, OSHA, of course, is the overarching protection statute as protections that relates to workers' comp. But workers' comp law is a state-specific legislative regulatory sort of framework. And so what I would tell you is, generally speaking, if you have an employee who doesn't follow the safety protocols at your organization, that doesn't mean that you're not on the hook for the work injury, right? So just recognize it. But do recognize that if an employee, let's say, refuses the vaccination and then, of course, does get COVID, you're on the hook no matter what. But I think it's important, if you think about this, to be tracking some of those statistics, right? To be able to say, 80% of our workforce got the vaccination, and here's how many of them post-vaccination came down with the virus. Here's the percentage of our folks who did not get the vaccination, and here's a percentage of them that has gotten the virus or has come down with, with a presumption of potentially COVID. So I understand what you're getting at, Mark. I think it's a good question, but as of right now, it's my understanding that you cannot really avoid that liability. Now, does that mean in your declination form, you might put, I understand, and I'm assuming some of the risk, because I'm not, or because I'm declining that vaccination? Well, I sort of jokingly say that's like the coat check sign that says not responsible for coats left in this coat check at the restaurant. They're totally responsible, right? They just put the sign up so that you think they're not responsible. They're responsible for the darn coat. So same things here. So let's see. Oh, is the link going to be available to employees to watch at a later date? Great question. And yes, it will be. The link will be out in the daily digest following, I think, tomorrow or Monday. It'll be out there for folks to watch. And then certainly, I'm sure, if I know Amanda, she'll have that thing rocking through social media pages for certain. Actually,
way ahead of you, Scott. She just put
and
it.
so Amanda also put Dr. Shepke's that video that we were talking about down in Florida. That one's in the chat link right now if you want your employees to see that. But if you were referring to this video link, I'm sure Amanda will be posting that up, not only in the Daily Digest, but probably will be out on social media. So number one thing, though, I want to make sure you know is make sure that you're educating your supervisors, managers, anybody in your leadership team how to recognize an accommodation request, because it may not come at you as, Randy, I don't want to take the vaccination because I have X medical condition, or because of my, I find it offensive due to, my beliefs. You have to go further than that, right? You need to go further than that and find out, right? Get those folks to say, oh, geez, I recognize this. Someone has used term of art, right? That I don't want to take this because I think maybe I shouldn't because of my medical history. Send them to your HR folks, or at least train them to recognize it, to then, sort of influence that person to go ahead and request that accommodation. vaccinations, there's some operational, and and probably Randy's got me by a bunch of years in operational experience. But one of the things that a lot of folks want to think about, and Randy, please chime in, are the logistics of doing or adopting a vaccination program. I don't know how you folks, I imagine AMR or GMR has got a plan, right? Because if you give this to everybody, and let's just say some folks have a couple days where they feel funky. I'm not even hearing that from some folks now, but are you concerned at all about the work, maybe doing too much of your workforce and what that might impact at one time?
I've heard this discussion around the country that if you had a mass vaccination day, and it appears to be this statistically, it's the booster, the second shot seems to have the more reaction. So yes, there is discussion of timing these out. Those folks who are in the air program, pilots, have a 48-hour downtime from point of vaccination until they can fly. So there, I think, are a number of cases that. So I think, yes, we are going to space them out over a time window so that you don't affect a whole daytime shift or a nighttime shift. And then obviously, to your point, Scott, dealing with the rules, and then the distribution and the logistics and some of those criteria are so state by state based. And now in many out west, it becomes very much county by county. So as an example, you may get asked the question, you've got 500 employees, well, you can have 100 doses in the next 3 weeks. So who are you going to give the 100 doses to? Do you do it as a random drawing? Do you do it by who's susceptible? Which with your collective bargaining agreement, if you have that. So I think there are a number of things that we'll continue to put out as the industry as a whole to kind of clarify that. But first and foremost, to your point, we're going to time out the distribution or the injection point or the inoculation, so that we don't end up with a factor of everybody done in a short period of time, and then you have to deal with that. The question to you, Scott. So you've made vaccination mandatory. I've received my second booster, and I've now got the headache and the fever, and I'm not feeling well. We know that's a 24-hour thing, but my shift is the next day. So is that a PTO day, or a sick day? Is that a workers' comp day? Or how would you see responsibility?
So these are the things that you should be, right? You should be planning out, right? Sort of failing to plan is a failed plan. So I think when it comes down to that, great question. If in fact you have an employee who misses a day or two because of the vaccination, my first thought would be that, of course, that would be covered as potentially, right? It doesn't really qualify as a comp yet because that's really just a reaction to that. But I would probably say likely if you're providing FFCRA, although the FFCRA leave option or obligation ends at the end of this year, although the tax credit option continues through the end of first quarter. But I would say, my suggestion would be if the organization's in a position to do it is yes, PTO, some form of paid time off, whether that comes out of a bank. Ideally, I think if the organization, this is what some of that CARES money could be used for, right? Is to provide some pay to individuals post-vaccination, right? And if you're going to use that money anywhere, that's probably one of the best places to use it, right? Is to say to folks, look, you get the vaccination, and if you end up having any negative consequences, or you end up feeling, not so well, you have an elevated temp for a day or two, we're going to pay you for those days, any shift that you miss. That certainly would alleviate, and that may be some of those concerns, because recognize for some of our folks, missing 1 or 2 shifts without pay is a pretty substantial or significant problem. So whatever you can do to smooth that path for folks, I think that's probably the best thing to do. Now, whether that qualifies as a comp, you could certainly report that as an illness. It would, would it be reportable? I'm not sure if under the OSHA guidelines that meets a recordable incident. However, in most states, the first 5 days are uncompensated anyways. And so my suggestion would be put together a plan organizationally where you would be utilizing some of those CARES funds to provide people with PTO. I think that's a great question.
So Scott, to kind of time manage this so we kind of end up on time, I'm going to give you you got about 5 more minutes. I know we don't want to, I'm sure you got great stuff on the slide, but I just wanted to give you a little time management.
No, that's perfect. It's perfect. We won't run over like we did yesterday, I promise. So I'm just making sure that you do have folks sign an acknowledgement. One, I would have them acknowledge, right, for those folks who get the vaccination, they're signing the acknowledgement and the recognition that they need to get the second vaccination. And then the declination options, as I said, we will put together, it is in process right now, a declination, just a sample form that folks can use. And in fact, actually, we'll add into that also an acknowledgement form that folks can use as a sample. Sometimes that's just a good way to get at least started in how all of that, it's sort of having some language to work from, it makes it easy. So, Mr. Strozyk, before we wind up completely, any final comments?
Well, I want to thank you and Dr. Ed, and this is probably the least I've talked, so I think mark that one down. Listen, I think this is incredibly important. We will continue to keep everyone updated. I have no doubt that come the first of the year, with the increased distribution of vaccinations, we see the state level responses, and then without a doubt, it just seems logical and imperative, and if absolutely necessary, states, counties, entities are going to have to turn to us as EMS providers to do vaccinations. There's no fundamental way that this country can't incorporate our people to do this. If we're going to vaccinate 100 million people, as President-elect Biden wants to have done, by the first 100 days of his presidency. So I think this will be a great opportunity for us to come across and show America what we've done for the last 300 some days. So as Scott talked about earlier, our recognition and our acknowledgement that we've received nationwide in the last 300 plus days is outstanding, and we've seen that. So we'll continue to work on that, make a point of that. Sharing information will be critical. If you run into an opportunity, you run into a problem, there's huge resources here. Scott's always available. Dr. Racht's available. We will track people down for our members to get information they need. And utmost, I think, Scott, I want to close out by having you go to your last two slides.
Yeah, so just I know for for folks who were on yesterday, I did I stole the Time magazine cover, People of the Year, Persons of the Year, and had pulled through a couple of these were covers that were memes on Facebook, and I thought were actually appropriate memes on Facebook, and these were actually covers of magazines. And to me, these magazines sort of portray EMS in a light that just could not be more positive. And I think, not that I'm underplaying the role that any other healthcare or public safety folks played, EMS, whether they be private, for-profit, not-for-profit, or public, really were, in fact, the linchpin in the response in this country, and have been for years. And I can't express my appreciation, gratitude to all of you who are on this webinar, to all of your staff, and to all of the team members, those even on the front lines and those in working behind the scenes, folks in fleet, folks in logistics, folks in billing, dispatch, and education. This has been an unbelievable response, and one that makes me proud to be part of the EMS community. That being said, it has also been a devastating year for not just EMS, but this country as a whole. But in particular, right, EMS folks put themselves in the line of fire at risk, and their families as well. And so I think it's important that we recognize, and I had all of the names that we know of, but then I was afraid, frankly, that I was leaving off a whole bunch of people who, by the way, were either family members who ended up getting COVID and succumbing to COVID because of their EMS family member bringing it home. We know it was a real concern. So it is not often that we are, this is a risky job. It is a incredibly rewarding job, but there are very real risks to our people. And I am grateful and just wish to express my appreciation to the families who are without someone at their holiday dinner table this year, and to all of you who lost a partner and or lost a coworker. a sincere thank you, and know that you are in, of course, our thoughts and prayers. And I know, Randy, you and I talked about this. This is a different type of holiday season, and we hope that this year, while I know we won't get to see all of our family members, sometimes because we're off visiting those family members we don't get to see often, we don't always get to appreciate the ones that we see every single day. Hopefully this year you'll get a chance to truly appreciate how fortunate we are. And I ask that, you enjoy that time. This will not be our last webinar on COVID, but it will be our last one, I think, unless one comes up in the next 24 hours for this year. So Randy, I know we did, I don't know how many, and I know it's been 26 since the last, but I cannot thank you enough.
I think this is number 8 we've done.
Yeah, so I thank you very much for offering the resources of your organization and your time. I'm sure if we took the dollar figure that was associated with you two and the time you've put into doing this, not just for GMR, but really for everybody in EMS, I can't thank you enough. And then lastly, I want to say a thanks to the folks at the AAA. Those folks who almost never show their face on camera are the ones who really, when I joke about Asbel and Brian being my safety net, truthfully, the folks at the AAA, Amanda, Meg, Maria, Tristan, those folks are truly the safety net under our little high wire act here, and we cannot thank you enough. So I wish you all a wonderful holiday season and cannot thank you enough for joining. And as always, if you have any questions, send them to info@ambulance.org. So with that, I pass it back to you. One last word.
Wear a mask, wash your hands. Please be safe. Thank you.
Thank you all. Thank you very much. We appreciate it. Have a good night.